we stay with wheals in the skin, but we will move from autoimmunity to autoinflammation. So I will talk about autoinflammation, pathogenetic concepts. I will also talk about the clinical picture, clinical clues and biomarkers we so far established for these diseases. And I will also talk about current treatment concepts and what the future will bring us for autoinflammatory diseases. So this cartoon shall mention the difference between autoimmunity and autoinflammation. So on the left-hand side we have the very well-known adaptive immune system, and on this guy you have autoantibodies and T cells primarily contributing to the disease. We have immune-mediated disease via lymph nodes, spleen and thymus. And on the right-hand side you have the innate immune system, and you have immunity which is mediated via so-called pattern recognition receptors, and not like receptors. And these are receptors that are found within the tissue. So we have usually inflammation which takes place at different organs, and this can be at the brain, this can be the eyes, this can be the lungs, also the gut, the joints, and also, of course, the skin. And so here we are lacking any autoantibodies, and the primary cells that produce these inflammations are macrophages, monocytes, neutrophils, but also mast cells. And so this cartoon I first mentioned was meant to really differentiate these two types. However, now we know that there's often also a disease continuum, a so-called immunologic continuum between these two. Autoinflammation here on the left-hand side. So these are often very rare diseases, and some of them I will mention to you within the next minutes. This is, for example, CAPS, but also other hereditary fever syndromes like hyper-IgD syndrome, TNF receptor-associated syndrome, or familial Mediterranean fever. And on the other hand side, you have classical autoimmune diseases like lupus, systemic sclerosis, or also pemphigoid diseases, which Sabine already mentioned. And then within this spectrum, we have diseases like Schnitzler syndrome, Still's disease, which have more symptoms of the innate immune system. And then we have more in the middle diseases like pyoderma gangrenosum, hidradenitis suppurativa, Behçet's disease, psoriasis, and these are all diseases that have, again, both. They have some aspects of the innate immune system, but also a lot of other aspects from adaptive immunity. And so what is critical for most autoinflammatory diseases is the inflammasome. The inflammasome is a multi-protein complex within cells. In particular, these are macrophages, monocytes that express this most strongly. And the inflammasome is activated via pathogens or danger molecules. The NLRP3, this is one of the receptors, so we have different inflammasomes, and the NLRP3 inflammasome is the best well-known one. And this complex is activated via these danger or pathogen-associated molecular patterns. In addition, we need toll-like receptor agonists like lipopolysaccharide to get interleukins like interleukin-1 beta or interleukin-18 produced, and then via certain steps like apoptosis spike protein and caspases, in particular it's caspase 1, that then leads to activation of the proform of these cytokines IL-1 beta and IL-18 into their active forms. And it has been shown that the inflammasome is really critical and relevant for a number of diseases. Once for very rare diseases like CAPS, the cryopyrin-associated periodic fever syndrome, but we now know that also for very common diseases like gout, like Alzheimer's, metabolic syndrome, but also very well-known dermatologic conditions like contact dermatitis, all of these are activated via the inflammasome. And the prototype IL-1 mediated disease is CAPS. CAPS is characterized by a mutation within the NLRP3 protein, and this NLRP3 mutation then leads, it's a gain of function mutation, to consecutive overwhelming IL-1 beta and IL-18 production and secretion. And what you can see at the skin, these are the urticarial wheals, very much like the wheals you would see in chronic spontaneous urticaria. You have eye inflammation like conjunctivitis, but also uveitis. You have bone and joint inflammation, CNS inflammation, and this often also leads to hearing loss in the patients. So it is a very rare disease, a very low prevalence of 1 to 3 in a million, and early onset in children, and so far there are a lot of different mutations that have been shown within the NLRP3 gene to contribute to this disease. There's another disease where we have a certain focus on. This is also a urticarial disease with, again, a typical urticarial exanthema, also very rare one, Schnitzler syndrome. Here you have, besides the urticarial exanthema, a monoclonal gammopathy, which is usually of the IgM variant, but can also be IgG or IgA, and systemic symptoms that mimic those of CAPS patients. But disease onset is quite late, so around 50 years. However, once the disease starts, it's also chronic without remission, pathophysiology widely unknown, and malignant transformation due to the monoclonal gammopathy may occur in about 15% of cases. And this is what you would observe here in the serum electrophoresis, this monoclonal gammopathy. But we already know that also the NLRP3 inflammasome plays a major role in this disease, and this work has shown quite nicely that parts of the NLRP3 inflammasome, so PT2X7, which gets activated via the inflammasome, is also activated in cells of Schnitzler syndrome patients. And if they are treated with an anti-inflammatory drug like prednisone, then this is here downregulated like in healthy volunteers. And IL-1 beta really is at the apex of an inflammatory cascade, so this leads to inflammation at brain, bone, and endothelial cells via different mediators like prostaglandins, like further cytokines as IL-6, and producing via the liver acute phase proteins and inflammation at various organs. But what are really the cellular drivers within the skin? And there comes again the mast cells. The mast cell, Sabine has very nicely shown in chronic urticaria, is primarily producing histamine and other mediators. But in autoinflammation, we know that histamine is not the mediator, but it is in particular the IL-1. And this work by a Japanese group has shown that it's again the mast cell which produces the IL-1 beta, which is shown here in the skin. And in a second study, they could show that the skin inflammation really depends on the mast cells by crossing CAPS knock-in mice, expressing a typical NLRP3 mutation with a mast cell deficient mouse. And as you can see here, this skin inflammation, which is also very typical in the mice, is only seen if you have this mast cell background, but not without any mast cells. And also in Schnitzler syndrome, we could show that cytokines, in particular IL-1 beta, IL-6, IL-18, and parts of the inflammasome, like caspase 1, are upregulated. And again, it's the mast cells that are producing IL-1 beta and IL-6 in the skin, and also the neutrophils that play a role by producing cytokines like IL-1 and IL-18. And if you're looking into skin histology of these patients, you can see here comparing a patient with Schnitzler syndrome with a chronic spontaneous urticaria patient, that there's a massive infiltrate here compared to this routine histology. And if you're looking into more specific markers, and here we chose myeloperoxidase staining, and you can see that neutrophils, which are here positive for myeloperoxidase, are massively upregulated here in Schnitzler syndrome patients as compared to urticaria patients. And what is also already shown here, that the neutrophils seem to really be very dense and to produce net-like structures. And these net-like structures we thought might be related to neutrophil extracellular trap formation, and indeed this could be shown. So neutrophil extracellular traps, neutrophils have the capacity to release extracellular DNA, which was first shown by the Brinkmann groups a couple of years ago to be important for antimicrobial activity against pathogens like viruses, bacteria, and fungi. But it has also been shown to be really important for autoimmune diseases like lupus erythematosus. And within this study, we could show that Schnitzler syndrome patients, also their neutrophils are more prone to make nets, and also their serum can stimulate netosis from healthy neutrophils. And in the skin, you can also see that you get these aggregated neutrophils that also do make these extracellular traps. And so the proposed mechanism, what we think takes place in these diseases within the skin, so we have mast cells contributing via danger and pathogen signals to produce cytokines like IL-1 beta and IL-6, and these then lead to neutrophil recruitment, and the neutrophils then further activate induction of nets, but also we have macrophages contributing. These are much less much less exposed in the skin, but we also know that these are the major producers of IL-1 beta, and so these also contribute to the IL-1 beta pools. And then we have IL-1 beta again attracting more neutrophils, and the neutrophils that then make these nets do make also antimicrobial proteins like cathelicidins, LA37, that then also again further expands the inflammation and makes macrophages to produce even further cytokines. However, we also recognize that these neutrophils do really aggregate, and that these aggregates also do produce proteases, and these proteases probably also have an anti-inflammatory effect via degradation of cytokines. So probably it has both pro-inflammatory and anti-inflammatory mechanisms. So coming back to the clinics, how can we really differentiate these urticarial phenotypes? So we have a lot of patients with urticarial wheals, and so which of them have the chronic urticaria, which of them have rather an autoinflammatory phenotype? So clinical clues are no or little pruritus in these autoinflammatory conditions, which is really not typical, but very typical for chronic urticaria. We have absence of angioedema, which is a very typical sign in chronic urticaria. We have the systemic symptoms and high inflammatory markers, and we have the missing response to antihistamines. And so there are a few biomarkers, serum biomarkers, that have been shown and tested in autoinflammatory conditions. And here you have autoinflammatory diseases like Still's disease, macrophage activation syndrome, here the familial Mediterranean fever and CAPS. And you can see here, so cytokine levels are a bit upregulated. However, this is for routine measures often difficult. Ferritin is something which often comes up here, in particular in Still's disease. We have the S100 proteins, which are known to activate toll-like receptors, which are often highly upregulated in all of these diseases. And we have others here, markers like the IL-33 receptor, ST2, and soluble IL-2, which is also of importance for Still's disease, but not for the other autoinflammatory conditions. We also look for certain serum or skin biomarkers ourselves, and CCL2 was one we found to be of relevance, in particular for Schnitzler syndrome. Here you can see a CCL2 expression in the skin, and compared to healthy volunteers, but also other inflammatory diseases like psoriasis or hidradenitis suppurativa, we could see that serum levels of CCL2 are upregulated here. This also correlated quite well with the disease activity of the patients. And if we are looking what is really producing CCL2, there it could be shown that it's again the mononuclear cells producing the CCL2 and the fibroblasts, but not keratinocytes or endothelial cells. And what makes them produce this? It's again the IL-1 beta that produces that makes the PBMCs produce CCL2, and in addition it is the TNF alpha, which at least in fibroblasts can also contribute to the production of CCL2. And so the proposed role of CCL2 in Schnitzler syndrome, so we have on the left-hand side inflammation at the bones and joints, and on the right-hand side inflammation in the skin. And so we think that IL-1 beta, which is of course known also to be important for osteoblast formation, that this triggers CCL2 production and tissue recruitment of blood monocytes, and differentiation of macrophages to osteoclasts, also the activation of osteoblasts, and that this balance of osteoclast formation, which is not really well in these patients, then leads to bone remodeling and the huge pain these patients usually have within the joints and bones. And within the skin, we have here the monocytes again producing CCL2 that also leads to differentiation of macrophages, and the monocytes and macrophages producing IL-1 beta and TNF that via keratinocytes leads to activation of antimicrobial proteins, and via CXCR1-2 ligands to tissue recruitment of neutrophils that then produce here the urticarial exanthema together with the mast cells. Now coming to treatment of autoinflammatory diseases, what do we have here? Of course, anti-inflammatory is really important, and in the past there have been a lot of different anti-inflammatory therapies, none of them really very effective, apart from colchicine, which is known to be really effective in FMF patients. Nowadays it's primarily an anti-IL-1 targeted therapy that helps many of these patients but also anti-IL-6 treatment, which is of benefit for some of them. And that this is really of importance is shown here again, showing you some of the long-term complications of autoinflammatory diseases, such as severe bone deformities, optic atrophy, less intelligence, and diminished growth, in particular in severely affected CAPS patients. Also something that many of these conditions can make due to the severe and chronic inflammation is amyloidosis, which then often leads to kidney insufficiency, osteoporosis, hearing loss was already mentioned, and lymphoma in Schnitzler patient. And so the first proof of concept that anti-IL-1 blockade is really effective came from this small placebo-controlled study showing that the IL-1 receptor antagonists, which which acts against both interleukin-1 beta but also the alpha subform. This was given to 18 patients, and within few days this really had a remarkable improvement on both clinical and inflammatory markers. And you can see here also from the clinical pictures before anakinra treatment and following a few days after treatment that all of these symptoms cleared quite rapidly. And so there's not just anakinra available, we have different anti-IL-1 targeting drugs so far. So this is canakinumab, a monoclonal antibody directed in particular against IL-1 beta, and here we have a study with Schnitzler syndrome patients, which was done at our centers and 3 other centers within Germany, and involved in 20 patients in total via 4 years. And here you can only see the first days of this treatment, and you can see here that the clinical symptoms went down very rapidly with the canakinumab treatment as compared to placebo, and also the inflammation markers like CRP levels or serum amyloid A levels and S100 proteins also went down quite rapidly. And indeed, there's also a number of other inflammatory skin diseases that are shown to respond, at least in small case series, to respond very well to anti-IL-1 blockade. This is again hidradenitis suppurativa, but also painful ulcers of the skin known as pyoderma gangrenosum, which are often associated with inflammatory bowel disease. The pustulous variant of psoriasis, Behçet disease, which goes along with aphthous ulcers, in particular within the oral mucosa, graft versus host disease, Sweet syndrome, which is a neutrophil-driven skin disease, which also goes along with fever episodes, but also cold urticaria and patients with urticarial vasculitis. So alternative options, I already mentioned anti-IL-6 treatment. So for some of these autoinflammatory diseases, it has been shown that IL-6 is also a driver of the disease. And here you can see Schnitzler syndrome patient versus healthy controls, and mononuclear cells from the blood of these patients, showing that they produce a lot more IL-6 as compared to healthy controls. This is also shown here within the skin, and if you're giving an anti-IL-6 treatment to these patients, you can see that CRP levels went down in 3 patients who were treated with this treatment here quite rapidly, and only if the drug was interrupted, these inflammatory markers went up again. So is this all anti-cytokine blockade? We don't think so. So there's also a lot of side effects sometimes associated with anti-IL-1 blockade, such as these painful injection site reactions. Also, this is a very expensive treatment. So we think that directly inhibiting the inflammasome could be of great potential in these diseases as well, and have the advantage of an oral administration, lower costs, and maybe be more specific. And indeed, there is first evidence of inflammasome inhibition by small molecules directly targeting the NLRP3 inflammasome. And this preclinical study with a sulfonylurea MCC950 could show quite nicely that this small molecule can downregulate cytokine responses, IL-1 beta, and this was also shown here in cells of CAPS patients, and that mice with the NLRP3 mutation, so CAPS mice who were treated with this sulfonylurea got a lot larger, died less often here, and gained more weight with this drug. So with this, probably as a future treatment, I would like to end. There are still some diagnostic and therapeutic challenges regarding symptoms, so a lot of symptoms may be unspecific or also incomplete. We have still problems with laboratory results, so there's still a lack of good screening tests. We often have to exclude a number of other diseases. Genetic analysis may be negative, so there are studies showing that even if they are typical clinical symptoms, up to 40% do not show the respective mutation. And regarding therapy, still we have the situation that for many of these patients we have to use off-label therapies because there's nothing licensed, and few data from randomized controlled trials and treatment in infants and pregnancy is lacking. So increased awareness is required, and of course an interdisciplinary cooperation. And with this, I'd like to thank you, and in particular the people who contributed to the work I've shown here at the Department of Dermatology, like Jörg, who is here, and Hannah, of course, Marcus, but also others here who are together with us here at the Autoinflammation Reference Center, like Eugen Feist and Hilman Kalini. And of course, you for your attention.